Hello everyone. Today we will study the thyroid metabolic hormones. This is the first lecture of our endocrinology series. For more videos, stay tuned. The contents of this video are the introduction, synthesis and secretions, transport, physiological functions of the thyroid hormone, regulation of the thyroid hormone secretion, and the diseases of the thyroid gland. So now beginning with the introduction. The thyroid gland is one of the largest endocrine gland. It is present below the larynx and anterior to the trachea. It releases two major hormones, namely T3 and T4, T3 being triiodothyronine and T4 being thyroxine. These both increase the metabolic rate of the body. The thyroid gland also secretes calcitonin, a hormone involved in calcium metabolism. The secretions of the thyroid gland are controlled by a hormone known as the thyroid stimulating hormone. In order to understand the synthesis and the secretion of the thyroid hormones, we must know the physiological anatomy of the thyroid gland. The thyroid gland consists of a large number of follicles which contain colloid. It is a secretory substance, and the sphere of the follicle is lined by simple cuboidal epithelium. The colloid contains an important glycoprotein which is known as thyroglobulin. The thyroid gland has a rich blood supply which is 5 times more than its weight. Now moving on to the steps of the synthesis of the thyroid hormone. This is the list of steps. Iodine is first trapped through the sodium iodide symporter. Then there's oxidation of the iodide ion through hydrogen peroxide. Then the iodination of the tyrosine residues or the organification of the thyroglobulin. Then the formation of monoiodotyrosine and diiodotyrosine. Then the coupling of monoiodotyrosine and diiodotyrosine, which forms T3. Then two diiodotyrosines, they couple to form T4. And then in the end, the storage. There's a few things we must know about T3 and T4. The thyroid gland releases 93% of T4 or thyroxine, and it releases 7% of triiodothyronine or T3. However, thyroxine is eventually converted into triiodothyronine or T3. Both hormones are functionally important, but T3 is more potent compared to T4. In order to understand the steps of the synthesis of the thyroid hormones, we must have a look at the diagram. In the diagram, we can see the sodium iodide symporter present on the basolateral part of the follicular cell. This symporter is responsible for iodide trapping. Iodide trapping is the first stage of formation of the thyroid hormones. In this step, the iodide from the blood is transported into the thyroid cells. Iodide is actively pumped into the interior of the cell. The sodium iodide symporter co-transports one iodide ion along with two sodium ions across the basolateral plasma membrane into the cell. The energy for transporting iodide against the concentration gradient comes from the sodium-potassium adenosine triphosphatase pump. This is a form of secondary active transport. Iodide that has been concentrated in the cell is then transported out of the thyroid cell across the apical membrane. It is transported into the follicle by a molecule known as pendrin. Pendrin is a chloride-iodide ion countertransport molecule. Along with iodide, thyroglobulin is also secreted by the epithelial cells of the thyroid. Thyroglobulin contains tyrosine amino acids to which iodine will bind. Thyroglobulin is a large glycoprotein molecule with a molecular weight of 335,000. Each molecule of thyroglobulin contains about 70 tyrosine amino acid residues. Thyroglobulin is synthesized in the endoplasmic reticulum and the Golgi, and then it is secreted into the follicles. Before the release of iodine into the follicles, there is oxidation of the iodide molecule. This oxidation of iodide is carried out by iodinase, which is present on the apical membrane. Only oxidized iodine is capable of combining with tyrosine. Once the oxidized iodine reaches the follicle, it binds with the tyrosine residues present on the thyroglobulin glycoprotein. Tyrosine then first oxidizes into monoiodotyrosine, then diiodotyrosine. and then these iodotyrosinase residues are coupled. Then the major coupling product formed is T4. Now moving on to the storage of thyroglobulin. The thyroid gland has the ability to store large amounts of hormones. Each thyroglobulin molecule contains up to 30 thyroxine molecules and a few triiodothyronine molecules. The amount of hormone stored in the thyroid gland is sufficient to supply the body for 2 to 3 months. The rate of secretion, as I mentioned earlier, is 93% for thyroxine and 7% for triiodothyronine. Thyroxine is then deiodinated to form triiodothyronine, as triiodothyronine is more potent. We've completed the synthesis of the thyroid hormones. Now we must know how they're released into the blood. Thyroglobulin is cleaved in order to give T3 and T4. Pseudopods extend from the thyroid cells and cause pinocytosis. This pinocytosis leads to colloid entering the apical surface of the cell. Lysosomes then fuse with these vesicles, which lead to the breakdown of thyroglobulin, giving T3 and T4 by the action of the enzyme protease. T3 and T4 are then able to diffuse into the surrounding capillaries. Some thyroglobulin also enters by endocytosis, once it binds with megalin. Transcytosis of thyroglobulin occurs from the basolateral part of the cell. Then thyroglobulin is also released into the capillary blood. Now talking about the rate of the secretion, as I mentioned earlier, there's 93% release of thyroxine and 7% release of triiodothyronine. Thyroxine is then converted into triiodothyronine by deiodination. Now talking about transport of T3 and T4 to the tissues. 99% of T3 and T4 are bound to plasma proteins, mainly thyroxine binding protein and much less thyroxine binding prealbumin and albumin. T3 and T4 have a high affinity for plasma proteins, so they're slowly released into the tissues. T4, however, has a higher affinity compared to T3. T3, however, has a higher affinity to plasma proteins, hence it is released in 6 days. However, T3, it has a lower affinity, so it is released earlier in 1 day. They both, however, have a slow onset and duration of action. Now let's talk about the physiological functions of the thyroid hormone. Before it acts, most of thyroxine is converted into triiodothyronine. This happens by the removal of an iodide ion from thyroxine. Once this happens, there is increased transcription of large number of genes. The next thing they're capable of doing is increasing cellular metabolic activity by having a calorogenic effect. Thyroid hormones also have a general and specific effect on growth. They promote growth and development of long bones. In children with hypothyroidism, rate of growth is decreased. Now talking about the metabolic effects of thyroid hormones. This includes the stimulation of carbohydrate metabolism. They stimulate all aspects of carbohydrate metabolism, which includes rapid uptake of glucose by the cells, enhanced glycolysis, enhanced gluconeogenesis, increased rate of absorption from the gastrointestinal tract, and increased insulin secretion. The second metabolic effect is the stimulation of fat metabolism. Lipids are mobilized from the fat tissue or the adipose tissue, as a result decreasing the fat stores of the body. In other words, it causes increased lipolysis, thus increasing the free fatty acid concentration in the plasma. The third metabolic effect is increased requirement for vitamins. The thyroid hormone increases the quantity of many bodily enzymes, and vitamins are an essential part of enzymes or coenzymes. So as a result, if there's deficiency in any vitamin, it may cause increased secretion of the thyroid hormone. The thyroid hormone also has several effects on the cardiovascular system. These include increased blood flow and cardiac output, increased heart rate, increased heart strength. The thyroid hormone also increases the rate of respiration, as well as GIT motility. And lastly, it has an excitatory effect on the CNS. Now talking about the regulation of the secretion of the thyroid hormone. TSH is released from the anterior pituitary gland. As a result, it increases the proteolysis of thyroglobulin. It also increases the activity of the iodide pump, increases the iodination of the tyrosine residues, increases the size and the secretory activity of the thyroid cells, and increases the number of the thyroid cells. It is also regulated by the feedback effect, which decreases the secretion of TSH from the anterior pituitary gland. This depends on the level of thyroid hormones in the blood. Now let's talk about the anti-thyroid drugs. These include 3 drugs. Firstly, thiocyanate ions, which inhibit the iodide transport into the cell. Then propylthiouracil, which blocks peroxidase, which is required for iodination. Thirdly, iodide in high concentrations also decreases the iodination. Now let's have a look at the very crucial part of this topic, which is the diseases that are associated with the thyroid gland. Excessive secretion of the thyroid hormones may lead to hyperthyroidism. The causes may include increased TSH, which occurs as a result of a pituitary tumor, or exogenous T3 and T4. One example of hyperthyroidism is Graves' disease. The size of the thyroid gland is increased, and there is tremendous hyperplasia. This causes increased release of T3 and T4. This disease is an autoimmune disease and occurs as a result of production of thyroid-stimulating immunoglobulins, which are produced against TSH, and they stimulate the thyroid gland to release T3 and T4. This may lead to protruding eyes as a result of edematous swelling of the retroorbital tissues and degenerative changes in the extraocular muscles. This is known as exophthalmos. Another example of hyperthyroidism is thyroid adenoma. This tumor is localized and it secretes thyroid hormone. The symptoms of hyperthyroidism include high state of excitability, palpitations, increased sweating, increased weight loss, muscle weakness, and nervousness. The treatment of hyperthyroidism may be surgical removal of the thyroid gland or radioactive iodide, which damages the thyroid gland cells, thus decreasing the secretion of the thyroid hormones. The other thyroid disorder occurs due to the decreased secretion of thyroid hormones, also known as hypothyroidism. This may occur as a result of autoimmunity against the thyroid gland. The example of this is Hashimoto thyroiditis. Another cause of it could be dietary deficiency of iodide, which is called endemic colloid goiter. Another form of it is idiopathic or non-toxic goiter. This does not occur due to the deficiency of iodine. The cause of it is unknown. In adults, myxedema develops in people who have almost total lack of thyroid hormone function. Such a patient demonstrates bagginess under their eyes and swelling on their face. They also have raised level of cholesterol, hence an increased risk of atherosclerosis. On the other hand, cretinism is caused by extreme hypothyroidism during the fetal life, infancy, or childhood. Congenital cretinism occurs as a result of congenital lack of the thyroid gland. However, endemic cretinism occurs by the genetic defect of the gland. This is all for today's topic. For more videos like these, stay tuned and subscribe to the channel. Feel free to leave your suggestions in the comment box. Thank you so much for watching.